Thank you very much. I must say that I'm sincerely thrilled to be here. Thank you for the invitation, the committee. Today, I'm going to talk about the route administration from a pharmacological point of view, why that the choice of it is very important to enable long-acting, as Charlie has already introduced, and also WHO Unit 8, they classify the long-acting technologies by route of administration. So these are my disclosures. So really three main topics today. One is going to be the rationale why long-acting. Unfortunately, have to narrow down to injectables because for a few reasons that I'm going to show you later, and then lesson learned at the TLCR program, University of Washington, led by Professor Ho. So there are many technologies, and each technology is associated with a route of administration. So, for example, I divided here in two big sets. One is on your left is a bit more early stage, and is has got many type of delivery systems from dermal, intradermal, or oral inhalation, mucosal delivery, and so forth. And possibly my colleagues later will pick these arguments up later. Today I'm going to talk about injectables because it's not only where we are focusing as a program, but as shown tremendous potential, as Charlie has already introduced. There are many enabling options from pharmaceutical point of view. You can have a long-acting injectables through a more classical way, typical classical way with PLGA, so microsphere technologies from antipsychotics is really well established from early 80s and so forth. Then you can also have long-acting injectables by selecting intramuscular and subcutaneous as the two main site of injections. And you can have nanocrystal suspension, long-acting cabotegravir and ripivirine. You can also have solution. You know, we should not forget that long-acting lenacapavir, as you can see here, is a clear liquid solution. And other, good technologies, promising technologies are the in situ Formigel and implants. And then it's us with a combination of drugs in one nanoparticles for one shot as a suspension, as I will talk towards the end. So why long-acting injectables? There are a few pharmacological reasons for that. One, it would be it might look obvious, but I will expand on that, is that we avoid the first pass metabolism. They generally have higher capacity to load the dose, and there are a few established ways to create long-acting suspension solution. Depot, but not only depot, as I will show you in a minute, and then there are drug combination nanoparticles as well we are developing. So from a pharmacological point of view, by avoiding the first pass, injecting intramuscularly or subcutaneously, over there, underneath the skin or in the muscles, you don't have much metabolic liability there. There's no substantial elimination of the drug due to enzymatic elimination. However, if you come from the oral dosing, a lot of drug doesn't make it through the first pass. The first pass is consisted of two main barriers. One is the gut, and the other one is the liver. So, because of a great deal of drugs are CYP3A, for example, substrates, or UGT, or PGP. So there are many components that oral drug has to transverse in order to get to the blood. And that, many times you have just a bit of drugs that can make it. And for that reason, poor bioavailability is a problem with certain drugs. So I'm fortunate to belong to a university that has studied very carefully, very thoughtfully, the oral first pass in terms of bioavailability, especially with lopinavir protease inhibitors. Protease inhibitors without ritonavir, which is a metabolic inhibitor, a strong metabolic inhibitor, it won't make it to the systemic circulation. For example, in human primates, lopinavir has bioavailability as 0. So there's all these complications related to the first pass, and one of the most important things is that it was discovered that the gut, already at the first stage, the gut is a big site of clearance, as our colleagues, our mentors, Kent Hummel and Danny Shen, they've done a seminal paper in the late 90s demonstrating that via IV and PO using the gauge drug midazolam. So it makes sense that if you avoid all of these because you take your drug, you put on an injectable, and inject it in the muscle or underneath the skin, you don't have to face all of this. And possibly you can also have lower amount of dose and expose it in an equal way. So first thing is long-acting injectable don't have to care a lot about the first pass, which is a good news. The other will be, and here is the example of intramuscular cabotegravir from left to right. Is left-hand side is the oral version of cabotegravir. On the right-hand side is the long-acting intramuscular depot. So what happens here is that when you formulate the same molecules as a microcrystalline suspension, then you inject it intramuscular, you form a depot. This depot is very stable. It's very static where you inject it. And what happens from there, the cabotegravir, the small molecules, has to be released over time, very, very slowly. It's like a drip thing that will feed the plasma over time. And pharmacokinetically, you're shifting the attention from I don't know how the pointer works here. Oh, there you go. So you're shifting the attention from the elimination side of things to the absorption side of things. And that is really what enables an elongation of your half-life of from hours oral to weeks, months on the right. Can we do that also with sub-Q, right? It's not just IM suspension. We can also achieve very long-acting, as Charlie already introduced, with sub-Q and a solution. See, is that this is quite clear. So why I'm saying that, repeating that, because solution might have, more easy way for bridging. And that was going to be very crucial, especially, hopefully my colleagues later, from a regulatory point of view, will pick this up. It's much easier to bridge that. So from a pharmacokinetic point of view, is you start from oral on the left, and you have it right, the very elongated profile for the lenacapavir. So what I wanted to point out here is that really pharmacokinetic parameters that you can observe by eye is that the Tmax. So the time to peak is very, very rapid when you do oral. It peaks very, very quickly. So when you have to treat, you treat straight away. It goes up to therapeutic levels. However, when you do long-acting, you have to take in consideration that the Tmax, so the rise to the therapeutic levels might be delayed. That's the question that many companies are facing. Do we need the oral leading phase to kind of support the switch and so forth? The Tmax is delayed for a few weeks, possibly. For long-acting cabotegravir is 1 to 2 weeks, and here lenacapavir is even longer. So I hope I've convinced you that intramuscular subcutaneous injectables, long-acting, anti-infective are an established and possibly enabling long-acting way to go, but I'm sure that other technologies can take inspiration from these pharmacological concepts. What I wanted to show you here is a study where they took 8 participants, gave them long-acting cabotegravir, IM, and doesn't matter if then effectively the depot was not really all the time IM, and it went sometimes, as you can see the green, it went, sometimes it's peeled out, it went to sub-Q, sometimes it's a mix of the two. As you can see, the time evolution from left to right is really maybe changing the depot. As you can see, what is stained in different colors is the depot of long-acting cabotegravir. But the point here that I wanted to make is that really it might change the shape over time, the evolution, but the depot is static, is there, and it will generate the profiles that you see on the right-hand side. Then there is a bit of a question of the localization of the depot will generate some variability, especially in the Tmax on the tails, but that is it goes beyond this presentation. So I wanted to wrap the kind of the pharmacological introduction and for long-acting injectable by giving a cartoon of a summary, a mechanistic summary of what's going on when we inject intramuscularly or subcutaneously. And a major sensitive physicochemical parameters of your product will be the size of your molecule, size of your particle, and I'll explain that in a minute. So when you inject in IM or sub-Q, you're actually injecting the interstitial fluid of the tissue. Here, the molecule, the particles are presented with two absorption routes. One is the lymphatic, which is a sort of drainage system, very permeable, but at the same time very slow. It's very permeable, it's very keen on very large molecules, cells and so forth. At the same time, you have the classic option of the blood vasculature, the blood capillaries, and which are very permeable to small molecules, but at the same time very fast. So if you can get through there, it's going to be swept away. Your molecules is going to be swept away. So let's say starting from the smaller case and perhaps a traditional drug like very soluble morphine, very small molecular weight, but for that sake also soluble insulin. Where you give it, they are quite small, so once they are in the interstitial fluid, they go directly to the blood. That's why those drugs have a very, very immediate peak, and they're also gone. They can also have access to the lymphatic system, but because it's very permeable, these molecules are very small, they just don't stay there. They don't pick that route. But then when you start increasing the size of your product, of your molecules or nanoparticles, for example, intermediate, I'm thinking about interferon or pegylated interferon, human serum albumin, like 50 kilodalton, you start switching from a blood-dominated uptake to a lymphatic-dominated uptake until you get to, for example, monoclonal antibodies, right? 150 kilodalton, and they're about 10 nanometers in size in hydrodynamic diameter. They go directly to the lymphatic system. And that is one of the reasons there is an important switch at the moment in the industry of switching from IV monoclonal antibody to sub-Q. Because sub-Q exploits the lymphatic routing. And that's why you see that you have more moderate peaks for monoclonal antibodies and a better therapeutic window, because the lymphatic system will kind of buffer in a more gentle way to the plasma. And then you have the classical long-acting injectables, where you have very large particles. Long-acting cabotegravir and lenacapavir, I'm talking about 200, 300 nanometers. PLGA, microsphere, they are in the range of micrometers. They're just stuck there. So really what their mechanism is really relying on releasing over time. So if you are a developer that is interested in a depot technology, you really have to design a way to control the release from the depot outside the interstitial fluid. And once it's there, there is no barrier, because the blood is a very fast sweeping system to get you to the blood, to the systemic circulation. So I'm going to talk about the TLCR program, the University of Washington, what we've learned. We have just completed phase 1 for one product, lopinavir, ritonavir, tenofovir, for HIV treatment. And we have other few products in the pipeline. The TLD, just demonstrated long-acting pharmacokinetics, non-human primates, and we will hopefully soon share some news also with first-in-human studies. But all this introduction is really to showcase that we can formulate multiple drugs in one shot. That is a difference compared to the landscape. For example, long-acting, so Cabenuva is 2 shots. One is Ripivirine, the other one is cabotegravir. We are spending 3 drugs and using lipids to create not very large particles. They are like moderate in size, but they are suitable for lymphatic uptake. That goes back to the previous cartoon. So how we made it? We made it because we are also taking advantage of an alternative route, which is low, and fortunately for us also is a good HIV target, because mononuclear cells do reside there. And those are targets for HIV. So by exposing the lymphatic system in a substantial manner, we are also able to load more antiretrovirals in LNMC, lymph node mononuclear cells, PBMC, more than plasma. And I will show you later. So just to put it in context, right, what you see up here is the upper panel is really the LAAI, as I show you, as I just shown you this slide before, and underneath is really our formulation, our product, how it works. So you inject it. So you inject it subcutaneously, and after some time, the nearby node lights up. And if you track it over time, you can see the next node lights up. And then if you open up the thoracic duct, which is like a big lymphatic collector that runs through the trunk, then we can also observe a distant lymph node that also is light up. And eventually, when you are near here, you have the lymph that dumps into the empties into the venous circulation. So nice mechanistic overview, but let's have a look at our first-in-human phase 1 concluded data for lopinavir, ritonavir, and tenofovir. What I'm showing you here is perhaps the first case that you can see protease inhibitors as a long-acting product. And on the left is single dose, on the right is still single dose, but dose escalated, and consistently the lopinavir is long-acting for 2 months after single injection in humans. But what was striking to us is that ritonavir that we left in formulation because of classic reasons of having the metabolic booster in it. It drops. It just doesn't make it beyond 7 days. That was a bit surprising for us, because coming from clinical pharmacology point of view, you will expect the protease inhibitors to stay high if there is a booster underneath to also sustain it, to inhibit the metabolism. Otherwise, the protease inhibitors will be gone. And this is one of the perks, of the advantages of having long-acting injectables, because you are avoiding that first pass where ritonavir acts. This is also an example that by choosing the proper route of administration, you can avoid some of these pharmacological considerations. So we might propose, it's been accepted recently, that for protease inhibitors, I'm not talking just about lopinavir, but think about the COVID-19, the Paxlovid is still given as an nirmatrelvir pill plus a pill of ritonavir. And ritonavir is notoriously known as a complicated drug to deal with in terms of drug-drug interactions. It's sort of, I believe that clinician will be happy to live without it. Another point, and I'm towards the end, is that by choosing the route of administration as a sub-Q, we're also enabling the gating of our dose through the lymphatic system, and that way we are exposing cells. Usually with classic small molecules orally, you don't have much inside the cell, especially the targets. And although I do understand that the target, also for regulatory point of view, is plasma, we should also consider that by enabling routing, different route of administration, you also have higher concentration in cells than plasma. All of this is wrapped up by a good collection of modeling. And we have models that can transform short-acting to long-acting, to IV, to sub-Q and IM, whether it's a depot or like a more moving carrier, including multiple drugs. That is done by a set of PBPK models, which I also encourage to utilize if you are a drug developer, because having a physiological understanding of your route is going to be key and critical to understand bioavailability and other considerations. To summarize, having a long-acting injectables has several advantages. It's not just higher capacity, 200 milligrams milliliters, for example, long-acting cabotegravir, that is only achievable with injectables at this stage. You avoid the first-pass metabolisms. You have several established options to do long-acting, like solution, suspension, PLGA, and so forth. What we've learned is that we might be making ritonavir redundant by using long-acting injectables. And please consider using modeling to support your development at regulatory stages. I would like to conclude by thanking and very grateful of this team. It's like a well-rounded skill set in here from analytics, from formulations to modeling and PK. And especially big kudos to Rodney Ho that is pushing all these products from preclinical to clinical stages for HIV treatment. And we are a non-profit, maybe the only one non-profit that is doing that. Thank you.